Well, thank you for having me back again. And
You're welcome. Thank you for coming and thank you for sharing your time and thoughts.
indeed, love to do this. It's a nice time to again think. And I was just being aware that a lot of our patients as well as our talks are around this concept of adverse childhood experience in ACEs. Where does your passion come from for talking about it, working with patients with that?
I think, like most of us, our journey comes from within, I think, and my own journey of healing led me to have to explore a lot of these things. And then I came across the concept of emotional neglect, childhood CEN, childhood emotional neglect, and then that led me into looking at adverse childhood events in a broader spectrum. And it just really fitted with everything else that I was getting to know about trauma, the history and origin of dysregulated nervous systems, chronic pain, chronic illness. And it makes a lot of sense. I thought it was lovely data.
Absolutely.
Which was and has been fairly robustly repeated, only to add to the sort of validity of the data, it seems, rather than question it or refute it. So it's lovely to be able to, in the sort of academic world, isn't it, and the clinical world, to sort of, it's so scientific world really says, well, I'm not going to believe anything until I've got some data, even though there may be some interesting things staring us in the face. So it's good for those of us that reside in that clinical environment, I think. And that's why I got quite excited, because I was like, right, I can state this, with some conviction.
Yeah.
How about you?
Somewhat similar, I think, in terms of the passion for doing something tangible with it. I found that very helpful. In some ways, I've reflected when I understand the literature now, I probably was spared a little bit of the extreme amount of ACEs that sometimes some of our patients go through. I've had maybe 2-3 of those questions answered. So I would say that my ACE score is 3 to 4 out of 10. But I don't think it really affected me to that extent, I would think. And that also made me aware that actually, well, what were the protective factors in my case that did not result in the kind of changes that can happen to the nervous or immune system in those who don't have that protective. So in some ways, becoming aware was maybe somewhat of a problem that I had with my own clinical practice. As a pain physician, I was dealing with patients. This was 2013, 14. I was a consultant. I'm still a consultant. I'm practicing at the highest end of my license. I can give strong drugs. I supposedly can block nerves and do all kinds of injections and nerve blocks. And yet I wasn't getting the kind of success I was taught in my training that these nerve blocks and medications ought to do. And that was the bit of reflection for me, is what critical piece of information was I missing? Something in the patient's stories. So I was listening more, and maybe something else that I wasn't taught in medical school. Yeah. And that's what got me looking into understanding outside, what else can be contributing to pain, to distress. And that's when I came across this concept of ACEs and trauma informed. And I often talk about it. The game changer book, in my view, was The Body Keeps the Score by Bessel van der Kolk.
Bessel van der Kolk's book, yeah, it's a great book.
And that book kind of opened, and that's what made me first aware of the ACEs literature. And I realized, oh my God, this is information that, like you, I felt needs to be made aware to every clinician that's practicing healthcare, that's looking after people. And trauma is so universal, yet we don't talk about it. it's again under the carpet, like the way probably depression and mental health was 10 or 15 years ago.
Sure.
And I think that's where my passion kind of comes now, is how many different ways can we get to talk about this so that this becomes commonplace. And for me, the main thing is we realize that when people face new things, sometimes they don't want to change because the existing status quo of healthcare allows you to function. They don't see the need for having a trauma-informed care. So I'm quite interested now in saying, okay, I believe in this. What will it take to get the person sitting opposite me, whether it's a healthcare professional or a patient, to also see my point of view? And that is a fascinating journey separately from the passion around ACEs.
Yeah. My wife works in education, and I recall having a conversation also with a head teacher of a primary school, and it's interesting, and we have some friends in education too, and I understand that ACE, Adverse Childhood Events scores, is kind of hitting education a little bit more, I think, than it's hitting healthcare, which is interesting. but it's so important there too. I mean, societally, I think it's a huge, the implications for it are huge. I mean, I was talking only yesterday with somebody about it, a friend on Zoom, and he was going, wow, we have to go, but this is huge. He said that we need to talk about this. When some I forget who it was now who postulated this, but he said, look, if we were able to actually remove all the ACE scores, if that were possible, I suppose life is trauma, right? Okay, but if we were able to do enough such that ACE scores were 1 or 0, then he said, look, our hospitals and prisons would be almost 80% empty.
Yeah.
Yeah.
As a thought experiment, yep, absolutely, I'd agree with you.
Go, well, okay, whether they're wild, but either way, even if it's 50%, it's vast, and that's how big it is. But the task ahead, as you say, how do I get people to pay attention to this? The task ahead of us, actually, if we were to address that at a political level. People have said to me, okay, so you seem to know a little bit about this. We'd like you to sit on a think tank to advise, at a government level about how we might understand some of these things in relation to changing healthcare and education. Then would you be interested? And I kind of somewhat tongue-in-cheek say, well, yes, on one condition. Well, what's that? You give me a 150-year plan that nobody's allowed to mess with.
Yeah.
Oh, we can't do that. Well, I'm not interested then. Well, why do you need 150 years? Because it's going to take at least 3 to 4 generations and a huge investment to make public awareness, probably free therapy for everyone, and buy-in from enough people over time to be able to. That's how big a task it is in my mind, which is almost unrealistic and impossible. So we just, as we do, we make small moves, I think, and we just do our best.
I think that small moves, it's two ways, isn't it, Rodger? That you're right. The scale, when you put it that way, feels really impossible or almost too difficult to make change happen. But I think the end point is what I'm hoping for, is even you said at the end there that small changes in our own ways, what we can do. And for that, there are some, promising shoots, green shoots of recovery, if you like. For example, Scotland had the courage and the innovation or the foresight to openly declare that politicians declared that Scotland will be an ACE-aware nation as far back as 2016 or 17, I think. They said they would really ensure that their social system, their educational system, even their justice system would really take on the principles of trauma-informed care and being ACE-aware. So if that's possible there, and there are parts of US which can do that, then I think the question, exactly as you said, why is that not come into healthcare? And to a great extent, I think we as healthcare professionals, the first step is awareness. Like any typical thing is just making us aware. And then I'm just interested to say, well, you know what, if you're aware, what are you going to do with that information?
Exactly, like anything. The first thing you've got to do if you're going to change anything in life, be aware of it.
Be aware of
You know,
it.
if you don't have any attention to the dials in your car, you don't know if you need to speed up, slow down, or do anything.
Nothing.
So
Exactly.
awareness is key. And you know, hey, this is why we're passionate about getting this conversation today and in our work collectively to get this out to the world. And yeah, I mean, you know, we can maybe move into, you know, well, why are pain clinicians and are people involved in the realm of pain and treating patients, actually, never mind pain, because I'm doing a lot more than treating pain, you know, and so we're treating people.
Yeah.
Pain is the thing that is the communication that brings them to us. Pain is just communication. It's saying, hello, you need to listen to me.
Yeah.
You know, and if we don't listen to it, it just shouts louder. And that will then go into inflammation and make you sick. And it did for me until I listened. And so, you know, why are we talking about what's the relevance of this to pain and ACE scores? Well, maybe we should have some conversation about how the connection of ACE scores is really playing out, and what does this word trauma that, I mean, you know, 10, 15 years ago, nobody was talking about trauma. But we knew what it was. We knew it was an overwhelm to the system, and now it's trendy and it's big and trauma informed. What does that really mean? Well, it just means we're aware of the impact of overwhelm and traumatic events in people's lives, and maybe a more complex immunoendocrine approach to health.
I think that's made the biggest difference. You know, to me, coming from both of us have trained in that kind of a biomedical background, as it were, but we realized that there were parts of the story that we learned in our medical and healthcare schools didn't really account for the patients with us there. And I think it's that in the research in the last 10, 15 years, exactly as you said, that endocrinology, the PNI, what was that? IE. That is now showing a more credible biological proof. So what existed very easily in a kind of psychological or psychotherapeutic setup, where in the 60s and 70s, because we couldn't prove any of these and these were all thought to be mental health issues, they lay in the domain of the psychologists and the psychotherapists, and probably there is still a big need for that. But what we now realized from your work, I think, and certainly in my work in the pain side, these are conversations that we need to be having in mainstream healthcare, because one, we've got the biology now to actually say that when you have that kind of continued stress on the nervous and immune system, it starts to play out in physical health conditions.
Yes.
You know, some of the data shows that not just chronic pain is 2 to 3 times more prevalent. There's some data that's come from the UK itself that talks about conditions like liver disease or autoimmune disorders or cancer or heart disease. They are all significantly elevated in people who have adversity in childhood and probably in adulthood. So I think the biological element is now robust. How do you manage this in your clinical practice? From your side, how does that present to you? The pain angle, for me, there are some things that make a difference in how I practice now, the trauma-informed practice. How do you bring the trauma-informed practice in your work? Too big a topic then, okay.
Well, yeah, how long have we got? Okay, I think, well, number one, I'm aware. Actually, my work now, I mean, it's blended. I've taken, you know, it's interesting. If I can segue off and if I wander, bring me back. I've just finished reading, and I'm not a fast reader. And to say that I finished this book in 2 weeks actually is an indication of how compelling a read it was. And it's from one of my teachers, Peter Levine, the founder of Somatic Experiencing. Yes. And he's just written, I had it on pre-order, it's just come out, the autobiography of trauma. And it's an autobiographical book of his life and the stories that led him to go on his journey. And the people that he's met along the way, people Stephen Porges, polyvagal theory, Bessel van der Kolk, they're all very good friends. And it was amazing to read his journey. And actually, it's lovely because you can tell I think he's quite old. I don't know how old he is. He's in his 80s, I think. And he's getting to a point in his life that I think he just doesn't care if people, what he says. He just doesn't care if people because he's not worried about being ostracized, because what the heck.
The joy of growing old.
And the benefit, again, I'm getting a little bit closer to that myself, I suppose, now. It's quite pleasant, actually. But he's gone on this journey also of looking at indigenous cultures around the world. And that's something that I did. I mean, this is part of my spiritual pathway and spiritual journey. Zen student for a long time, and a philosopher. And I've looked at cultures. I think that's very interesting, these cultures and how they deal with trauma. And there's a collective, there's community, which is Porges' idea of co-regulation, if you will, in communities, and regulating each other's nervous systems. They've used rituals, dance, hallucinogens, and here we are with ayahuasca and all the research around ayahuasca and such things in controlled environments for managing trauma. And they've done this. And they didn't have the internet, they didn't have airplanes, and they weren't even aware that anybody else on another part of the planet existed. And when you look at these people who derived their own understanding with the only tools that they had, the similarities that you notice when you examine these indigenous cultures is really, really quite interesting, in my experience. And it's interesting because it's there in Peter's book as well. And so, my journey clinically has been physiotherapy, acupuncture, Chinese medicine, craniosacral therapy, Ayurveda, energy medicine, trauma release exercises.
So you've had a lot of interest and training in so many other things outside of your...
And then when you begin to look at these things, I was thinking, right, how can you look at the energetic system as through all of these other ideas, through the lens of a sort of neurological angle? And so I suppose, to answer your question about, well, how do I bring that into my practice, it might be, I'm not very purist, and it might be, well, okay, now maybe I'm looking at some light touch, myofascial approach, and kind of going, yeah, well, what's happening here? And it might be I supplement that by going, aha, yeah, so that's the emotional release that's happening in response to this light touch technique. And it might not be that I take a purist SE, somatic experiencing, or somatic psychotherapy approach. Because if that's not right, you meet the person where they're at. And if they need touch, if they need contact, but I'll modify it probably to now go, well, it's not such a passive experience, it's a much more integrated experience. I certainly, in my questioning, I go deeper into why. And, okay, well, I started this thing and I asked myself, okay, but why? And really the clues in the history, there's a young lady I've worked with for a couple of years now, came with chronic pain and then Tourette's. Before she'd seen me, she'd seen, I think, 2 neurologists, pain clinic specialists, not you. No. She would have been much better off had she seen you, Deepak, of course. She would have been referred much quicker.
Oh, there you go.
So, psychiatrist, I think, orthopedic surgeon. And they just said, oh, you got functional neurological disease, FND. Okay, sorry, can't help. Word of mouth, came to see me. And I'm not exaggerating, in about 20 minutes I'd gone, aha, well, there we are then. Because I said, okay, what started? Well, I was about 19. So this is an example of how I might just simply ask the questions differently. That's, I think, the answer to your question. How is it different? I answer the questions through the lens of an understanding of the human body differently, instead of like, well, did you fall over? Did you hurt yourself? Was there a mechanism of injury to this? All of the classical stuff. Yes, maybe, but if that's not apparent, well, what did you start with? I started with the pain. So you didn't have any tics. You didn't have any, no, I didn't have that. I had the pain first. Okay, so you started with the pain. How old were you when you had that? I was about 18. And when did the tics start? When I was about 19. Okay. So 18. Before your age of 18, any pain, any car accidents, any... No.
Nothing.
Okay, nothing at all. You know, the usual thing. And you can't find anything, at which point most people in the past would go, I'm stuck.
Yeah.
And I went, okay, was anything big happening in your life at that time? You know, what was going on for you at that time? You know, were your parents divorcing? Did you break up with a boyfriend? Did you bereavement? Was there something big going on in your world? So that's the trauma-informed approach for me. And I could have ended up, and I did later go on to early years as well. And neurodevelopmental psychology and things as to how her system had already, and it was that plus that, I think, that created the problem. And she said, yeah, I just got out of a sexually abusive relationship with my boyfriend. I went, well, that would do it. And all of a sudden, I understood the origins of the incomplete motor responses that were causing these motor tics.
Yeah.
So, yeah, sorry, a long-winded answer there to your question,
No.
really, but how is it shaping it? I think the history and understanding of the complexity of the mind-body relationship.
Completely. I think it comes with the set of skills, and you rightly said, for me also the history really makes a difference.
Sure.
And you're absolutely right. The way we ask the questions, way we frame and introduce the whole thing, I think that's what really changed for me with bringing my version of trauma-informed practice into my clinical care. Because for me, obviously, I'm already prescribing, or rather I have the potential to prescribe strong opioids, which do right now have a problem in being dependence-inducing. Mm-hmm. And then I do a lot of injections and procedures or referrals for surgery, which have their own potential for harm if not communicated properly. So for me, the biggest revelation of understanding the ACEs literature and being trauma-informed in that sense is, like you, giving that space and time to the patient to tell me their narrative and look for clues on where their nervous system and immune system might have become rendered vulnerable or become amplified over the journey of 5 or 10 years before they come to see me. But then after that, it becomes a guiding light, because if I know they have experienced trauma or they are more vulnerable, then I'm cautious in how I frame the positives and negatives of any intervention, whether it's a drug or an injection. I'm a little bit more cautious. And I think if I contrast to what I was 6 or 7 years ago, I probably would be saying that I would have been much more laissez-faire. I would have said, oh yeah, we'll give this drug, we'll try this, I'll see you in 3 months, and then we'll think about it. Now I'm much more mindful about how I frame the conversation about the drug. I still do not deny or say you can't have it,
Sure.
But it's about just being mindful. And I think that's what trauma-informed approach to consultations need to be, isn't it? Just that attention to the patient's history.
I think so. And as again, it's not for us to say, well, now we must have this approach or we must throw away the baby with the bathwater. No, not necessarily. At the end of the day, I don't think there's a benefit sometimes to if something is just there's so much going on, then some appropriate use of citalopram, some antidepressant, some medication or that may actually be useful, because it doesn't, as long as you don't numb it completely, then it may mean it's just that little bit more tolerable to be able to start to titrate the issue. But yeah, I mean, I just as you know, I just come out from doing some clinical training with my team and my colleagues, and my colleagues sort of said, oh yes, I've got somebody with CFS, chronic fatigue syndrome, and I'm sort of doing this with them, and they're great people, great clinicians, but this is the beginning of understanding this more mind-body approach. And I thought, well, wonderful question, but we've only got an hour.
But given where you are now, you're doing the training. I also do teaching there. What do you find? Certainly, I would say that your way of thinking is going to be very different from maybe what a lot of other physios or a lot of other professional things. I certainly know that the way I practice and I talk about trauma-informed care is different from my colleagues as well.
Yeah.
Why do you think that is? What's your take on why your professional colleagues are not much more accepting readily of the mind-body approach?
Yeah, so look, I think there's two types of people. Sorry to generalise, but I'm sure there's more. But I've found that there are two camps. There are those that are excited by what we don't know, and there are those that I think possibly are terrified by it. Maybe I don't know.
A human tendency to probably resist change.
Yeah, maybe we could look at it through the lens of, early adopters and laggards.
Oh yes, the innovation thing. Yeah,
the innovation theory. We could look at it through that as
No.
well. So I suspect it's just humanness, and it's no better or worse. It's just we're all somewhere in that way, and our resistance to change maybe around our profession might be different to how it is in our personal lives. So, there are those people I think that go, well, look, I like a framework and it's good, and I just accept that 80% of the people that get better with my spinal surgery, and that's great, and the 20% I go, never mind. And for me, that's not good enough.
No.
I like to sort of try and push myself by going, I want to understand why I'm not able to help that person. And so for me, I think there's just different people's attitude towards expanding their knowledge or feeling safe and comfortable in the realm that they are and the pace at which they wish to expand.
Acquire them. It's very weird because I think I agree with you completely. I think the innovation thing really resonates with me. I think the fact that there are some people who are going to be early adopters while others will need a whole lot more logic and evidence and papers and systematic reviews and meta-analysis, and cause and effect has to be absolutely proven before they accept that change is worth doing, and they'll have to have a couple of, as you said, some guidelines to guide practice as well. But the reality is with things like ACEs, you can never get cause and effect. Imagine an experiment ethically where you decide to inflict adversity on someone, then watch over a 15-20 year period what evolves. I don't think that's ever going to happen.
Good luck getting the ethics.
Exactly. Good luck getting the ethics for that. I do think that early adopter option is possibly worthwhile because there's, for example, like you may be aware that there is this new branch of medicine that's become much more common in the last 3-4 years called lifestyle medicine.
Yeah.
It's been there for about 10 or 15 years in the US, it's been there in the UK as well. But in the last 4 or 5 years, there is a lot of primary care doctors and even secondary care consultants and other healthcare professionals, not just doctors, who are all saying, well, you know what, this way of doing medicine, which doesn't take into account public health, prevention, all the other lifestyle options that can contribute to worsening of long-term conditions, whether that's depression, diabetes, they're all saying, well, we need to do things different. And to me, that is another place for a little bit of hope, because if you've got a bunch of people already willing to change some of their beliefs to incorporate things like lifestyle medicine, I sort of think, okay, you know what, this group of people might be the early adopters to also take on a trauma-informed approach because they're anyway doing change. And I think like the way we do in surgery, we talk about this teachable moment. Because when somebody is coming for surgery to the hospital, we think of those patients as people who are in the throes of change. They have to make change because they are going to undergo something that's big. It's an opportunity to introduce all sorts of new things to them so that they'll take up new habits. So maybe going for approaching this group of people, and so some ways I'm less worried now about my immediate colleagues, all of them becoming trauma informed. I'm more about saying, well, which group of colleagues are undergoing change of a variety of kinds, whether professionally or personally. They are the people to probably reach out to for trauma informed care awareness, because if while they're taking new things, they might as well take this new thing as well.
And of course, we've got I'm just as you're speaking, I'm thinking, and that's half of the battle. And the other half, in fact, the bigger half, of course, is the public's approach to it and their readiness for it.
Yeah.
Often, actually, I find that people there's almost an unconscious part of them that brings them, and they are aware. And sometimes I'll start my conversations with the patients, sometimes in a particular way, and I might just see what comes up, and I'll say, oh, that's interesting. I don't know whether if they don't particularly know that they're coming to me particularly for that, but they're just coming with a complex problem, and I might say, look, I tend to look at things in a slightly different way, and so please excuse me if we start going and exploring into backstory and history because of my understanding of the mind and the body and sometimes people will say, oh wow, or that's music to my ears, and I'm like, okay, good, we're going to be fine here, and
exactly.
and they'll go, oh yeah, well, do you know, I've been going with this irritable bowel for years, and these migraines, and this pain in my neck, and I'm like, yes, well, I will probably see all of those as
a combination,
connected things, and they're like, hallelujah. And we're taught with this reductionist thinking, and I think that's the thing that we need to almost take this down to training level, isn't it? As our biomedical training backgrounds, is that we need to be training people. We have to take something apart to understand this is the knee, this is how it is, this is the heart, this is how it is. We have to be able to take it into its reductionist parts, but then we somehow seem to forget to put it back into a system, into an organism.
Yeah.
And, even so much so that you get, I had somebody work for me once, and it was very much at that time where the pain is brain and idea and Lorimer Moseley and all of this work, which is wonderful work, I'm not knocking it, and central sensitization and all of that. And actually had somebody come to say, and she got almost so blinded by the masters that they were doing. So I said, well, no brain, no pain. And I said, no heart, no pain, dead. I said, we're a system.
Yeah.
And actually, you can't feel pain with your brain alone anyway, because there are no sensory nerve endings. So without a body, to separate these things out is futile. And I really, whichever way we look at it, if we're not careful, even we just say, well, everything's is trauma informed. There's lifestyle medicine. There's just, dare I say, holistic, without sounding like I'm, going to start growing long hair and being a hippie. But their truest
So that's the
sense.
problem with those words, isn't it?
Exactly.
You think of that only when you say holistic, but you're right, actually. Those words actually carry all sorts of meanings and stereotypes with
It's a whole. Let's look at the person as a whole. We treat people, not parts.
Agree. And I think trauma-informed care really brings that, isn't it? Makes it more universal, makes it more that we always pay attention to the person, not just the pain and the area of the body that the pain comes from.
And their story.
And the story.
And the story, is important. People's story and the history. History taking is an art. And to your point, I was really saying, well, how has it shaped my work? Really, the history taping, the example I gave, albeit brief. Taking our history, I think, is something that can be taught. And I was doing that today. I was saying, okay, right, fine, there's your history. Now expand. Go fishing. Because if there's nothing obvious, go fishing.
Yeah.
We need to explore. We need to be detectives. And that's something that I think we when we broaden out, we start thinking beyond the logic path that we've got. When we broaden into different ways of thinking and thinking about how the ACE scores, how life impacts things. And then, how does that? Well, let's look at epigenetics. Let's see how that is. Now, also, therefore, what's the, we could sit there and go, well, the ACE score suggests that your ACE score is 3 means you're 4 times more likely to have a heart attack or stroke. Fine. Okay, but that can be a bit pessimistic. I also like to think about the potential reversibility. That actually, we have neuroplasticity.
Yeah.
I'm working with people to change the way their nervous system actually responds, because that's how trauma, of course, may affect at least the nervous system, is how they're going to take a particular pathway. And so if we're able to work with changing that pathway, that's neuroplasticity, and also we're changing that biochemical environment and the soup in which we bathe the DNA, then of course,
Well said.
if that has the potential to change the expression of the DNA in a particular way to manifest as XYZ, then I like to open the possibility that we can reverse these things by changing the environment of the chemical soup.
Agree. I 100% with you on that, and I think the way you used and explained the epigenetic concept is absolutely spot on, and that's where I see the potential for recovery. I don't know when we spoke last time I mentioned or I talked about it. When I first wrote about and I got the title of the book, Pain-Free Mindset, I had people in my hospital, some of my colleagues coming and saying, you can't call it pain-free, that's like promising too much and that's like clickbait. And I was myself hesitant at that time, little bit worried about the response from my own peers, as in they seeing through and saying you're calling something that's not, you can't promise that to our patients and lead them on a path. But actually more than ever in the 5 years since I got the idea, the books come out and the stories that I hear from patients now, I think when trauma-informed care can be practiced, when you identify and you work with the right professional, it's possible to become pain-free.
It is.
I've got so many patients who have recovered, and after 10, 15 years, right now, there's the rounds doing of an article in Medium by one of the patients that I know who's had chronic pain and ME for almost 20 years. And she has gone on almost a mission, a passionate mission for the last 6 to 9 months, using every avenue and forum and conversation to talk about how she has become pain-free and what she did to work on her traumas, to use neuroplasticity and recover.
Well, indeed, and not just the pain, but that's my story. I resolved my pericarditis through this work. It took, and actually a lot of the work wasn't really pulled together, so it took me 7 to 8 years of pitfalls and progress and fallbacks and all sorts of things. Every time it came off the prednisolone, off the steroid, it came back until I did the work. And now I have not had any pericarditis in over 10 years. Yes. And so,
how much time did your work take actually? Like from the time you realized and you became aware and you did the work, did you get help at that time, or did you take, how long did you think it took at that time?
Unfortunately, there wasn't an awful lot out there that I was aware of, and this wasn't really. Of course, people like Peter Levine, they were out there, but I was unaware. Yeah. They weren't really. It wasn't really available. It wasn't packaged up in this way, so it's why it took me so long. It took me 8 years. But in amongst all that, there was years of psychotherapy, getting so far with that, then getting stuck with that and realizing that the body was missing within that, and hence the somatic approach, looking at really using what I'd done myself and then learning what I'd done myself, and sort of craniosacral techniques, and within that there was something called somato-emotional release, where you would get emotional releases when you were working with the tissues, and I was curious about that and exploring that. I didn't get a lot of body work, but I did an awful lot of mindfulness, did a lot of meditation, did a lot of self-manipulation of energies, recognizing my own patterns. So I actually kind of had to do it on my own a lot, actually, without the assistance of others, although that has gone on in latter years, to find other professionals to support that. So, it is a long journey. I'll say to my patients, look, it probably isn't 8 to 10 years for you, don't panic too much, but it can be a couple of years of work for people. It's not a 6-week journey.
No, not at all.
And people are like, wow, gosh, and I'm like, well, you've had 30, 40, 50 years of a patterning in your nervous system, and why do we assume that we're going to shift neuroplasticity and biochemistry in 6 months? Because we're not. No. You can have radical changes very, very quickly, actually, very, very quick changes for some things. But I think
overall it does, you're right.
I think it takes time.
And I think supporting the patients during that period, keeping the hope, keeping that recovery aspiration still intact, that is also a work in its own kind, isn't it? To not
It
let
is.
them lose hope when they have a flare up or they have a dip, because neuroplasticity is never going to be linear in one direction.
And I have to do that all the time, and actually it's one of the things that my patients do sort of often comment upon, that they value the fact that they know that I've sat in that chair and I've done the hard yards and I've cried and I've wept and I've struggled with feeling like it's not working, and so I think it does something to help bolster them to know that I am, kind of living proof.
Been there, yeah.
And that I'm not just making this up because I've read a bunch of books.
Yeah.
Yeah. So the reversibility is a very real thing, and I think that's the reversibility versus living with something, I think, is important as well, because a lot of people talk about living with these things. I mean, the connection also with this teaching thing I was doing just earlier today. A colleague asked me about this chronic fatigue syndrome, and I sort of said, "Oh, are they on any medication?" And he said, "Yes." I said, "They on citalopram?" He said, "Yes." I said, He said, "How did you know that?" I said, "Well, probably got depression, right?" I said, "Yeah." He said, "Why?" And I said, "Well, what is it? What is it to depress? Well, what is depression?" And actually, because he's been working with me for a little while, and he said, "Well, it's a suppression of emotions." I said, "You see, right." Because most people would probably have said that it was low mood or it was low affect, and but actually, what is it to depress? Is to push down. So we are suppressing
Something. Yeah.
And I had a teacher on my journey say to me, imagine taking a big giant gym ball, a big Swiss ball, and being in a swimming pool and pushing it down. How much energy would that take? Day in, day out, week in, week out, month in, month, year in, year out.
That's a powerful visual metaphor.
Okay? So why so much depression with chronic fatigue and ME? It's exhausting. So how do we treat this? Not the way by progressive exercise plans and so on, because they just, I did that years ago and they just crash again.
Yeah.
What was the missing piece? It's going, why is the energy being consumed? And yes, of course, that can go into, is that how their body is processing or not processing the emotions and what that's doing? And I think that links nicely to the broader spectrum of lifestyle medicine, because, if we're not sleeping right, if we've got a bunch of stress going on, if we're kind of not exercising, if we've got the poor diet, etc., of course, all of these things
will feed into the pot.
Working 14 hours a day, 7 days a week, well, of course, these things are important. And are we just getting constant stimulation from the phones, which we all have, but how we find the balance?
Yeah.
An old Chinese medicine teacher of mine many years ago, said to me, everything in life is about balance, and he was totally right.
I thought you were just going to give me some line from Kung Fu Panda 4. That's good, at least that kind of Chinese thing works out.
Yeah. Why do we call it the present? Yeah, because that's why we call it a gift. Yeah.